Well, thanks so much for being here. Excited to have you. Today, we're going to talk about complications that can occur from bariatric surgeries. So maybe you can talk about, in my understanding, there's sort of two main procedures. There's the Roux-en-Y bypass, and then there's the sleeve gastrectomy. Am I right about that?
Yep, absolutely. So, yeah, and there are definitely other things that still show up, like gastric bands and things like that. But for the most part, it's Roux-en-Y gastric bypass and sleeve gastrectomy. And I think, yeah, for folks that are seeing these patients that may show up in the emergency room after either procedure, there definitely are some specific conditions and specific things to look out for that may not necessarily show up on initial examination or even on imaging sometimes. So I think, the biggest things to consider are really related to gastric bypass. So it's not done as frequently as sleeve gastrectomy nationally, but it definitely is a very common procedure. It's still what we compare other procedures to when they come about because of how long we've been doing them, over 60 years now.
What are the indications to do one or the other? Like, why do some people get one? Why do some people get another one?
Yeah, so great question. So the sleeve gastrectomy, one of the reasons why it's become more popular is that it still has the same effect metabolically, very similar to what a gastric bypass has, but it does have less long-term complications in terms of ulcers and bowel obstructions and some of the things that we'll talk about. The specific reasons why it may sway someone towards a gastric bypass really come down to two conditions. The biggest one being reflux. If someone's got bad heartburn, bad gastroesophageal reflux disease, the gastric bypass is going to be a much better anti-reflux operation. The sleeve gastrectomy actually can induce reflux or make reflux worse in certain patients. So that's, again, probably the biggest distinguishing factor. But weight loss is slightly higher with the gastric bypass group than with the sleeve, but again, we're talking about maybe 10% difference when you're looking at 5-10 years after these operations. So that's why the sleeve gastrectomy has become more popular in the past 10-15 years, because the outcomes have been very similar, but the risk profile in general tends to be a little bit lower.
Okay, great. That's very clear. All right. So let's walk through some of these complications. So maybe we could start with the more complicated one, which would be the bypass.
Sure. So again, done laparoscopically. Usually it's an hour to two for surgery. Usually they stay in the hospital one night. Most of the perioperative complications are going to be true of any operation. So things like bleeding, infection, blood clots, leaks, those are the things that we worry about the most because of that connection that we make. And in that operation, we are making a small pouch of stomach at the very top of the stomach, and then we're dividing the intestine and then bringing that up and making a connection between that pouch and the bowel. And that is a potential for problems like leaks because of that connection between that pouch and the bowel. That's not a normal connection. The bowel's never used to seeing undigested foods, and the acid that may still be produced in that small bit of stomach may be enough to induce some of these things that could cause a leak, could cause an ulcer, and other complications like that.
Okay. You mentioned, like, up front, we're talking about your infections, your bleeds, your clots. Those in the emergency department, I think we're pretty good at picking up on. But the leaks part of it, how would we go about assessing whether someone is having an anastomotic leak?
Yeah, so if they were to happen again, they can happen those first week or two after surgery. The most common clinical findings initially could be intolerance of PO intake, nausea. Tachycardia is one of the things I always teach my residents and floor house staff to look out for, because oftentimes, because of their morbid obesity, because of other abdominal factors, they may not present with peritonitis. They may not present with even abdominal pain sometimes. And so tachycardia can be that really first initial sign of either dehydration. Obviously, it's a broad clinical indicator, but that can be my first indicator, especially after bypass, that something is not going right. And so that workup typically involves a CT scan with oral contrast. And we have a protocol with our ER physicians that if someone shows up after a gastric bypass or a sleeve, especially in those first couple of weeks, that they're going to get a IV and PO contrasted CT scan of the abdomen. We're usually going to add on a chest PE protocol CT as well to rule out a PE at the same time. But I do want them to get at least 50 to 100 cc's of oral contrast right before the scan, because that's where I'm most concerned about the esophagus, the pouch, and hopefully that'll identify a leak, a bleed, and rule out a clot. So kind of covering all those bases with that exam.
Okay. So you would see PO fluid extravasating out from
Yeah.
that
I mean,
area.
again, luckily I've been lucky in 10 years of practice that I personally haven't had a leak immediately post-op, but that, it's the nature of the beast when you're doing any kind of anastomotic surgery.
Gotcha. So low suspicion to scan these immediate post-op patients for both
Yep.
PE and for leaks, infections, all that.
And I think, what I again try to tell my folks in the ER at my hospital is early recognition of the fact that they've had a gastric bypass and then getting the appropriate imaging, a CT scan, is really important.
Okay, gotcha. All right, so let's dive a little deeper, one by one,
Sure.
through the complications. So we talked about the early complications, but let's talk about the more late complications that can occur, and we could start with the Roux-en-Y.
Right. So I think, again, we talked about the early stuff as the things we just mentioned after gastric bypass in the first couple of weeks. The two biggest potential issues long-term after gastric bypass are a marginal ulcer and an internal hernia causing a bowel obstruction. So the marginal ulcers, again, because of that abnormal connection between gastric mucosa and bowel mucosa, there can be an ulcer that forms at that connection. And it's typically on the bowel side of the anastomosis because, again, it's seeing things that it shouldn't normally be seeing. All things considered, it's actually a pretty rare complication. I mean, we see maybe one or two a year of those issues for all the gastric bypasses that we do. So they're a relatively rare complication. So again, if someone shows up in the emergency room, they've got intractable abdominal pain or kind of gnawing abdominal pain, we get the CT scan, which doesn't show anything else more concerning. Typically, the next step would be getting GI involved to do a endoscopy, and that's the most important part. You may see it on CT scan as kind of inflammation around the anastomosis, but an endoscopy is going to be the first test to really identify, is the anatomy appropriate, is there an ulcer, and then what the next step should be.
So for these marginal ulcers, in terms of how emergent are they? Is this something that the diagnosis needs to be made in the ED? Is this something that, is sort of insidious and needs to be diagnosed over a week or two?
I think we see all comers. So, there can be the patient that shows up with peritonitis, with, all the signs of a perforated ulcer. And obviously that person needs potentially urgent surgery or surgical intervention, or a bleed for that matter. Same deal as, any other duodenal or gastric, ulcer. If they're presenting with peritonitis, if they're presenting with perforation, if they're presenting with an active bleed, then they will need either surgery or, close GI intervention to deal with it. The more common scenario is that someone's got this kind of gnawing pain that's been going on for a week or 2 weeks. They've been chewing Tums, they've been, trying to self-treat it, and then they finally show up in the emergency room because they just can't deal with it anymore. Those often, if they're the most common scenario, and we always counsel our patients to prevent these, is to avoid things like smoking, and then NSAID medications, things like Motrin, Aleve. Those are going to be the biggest culprits for these ulcers forming. And so if those are and then alcohol abuse, other drug abuse are again, the more common scenarios for these ulcers forming. So, assuming those things are treated and not being used, most of the time these ulcers will heal with high-dose PPI therapy over the next few weeks, and then we recommend a follow-up endoscopy 2 to 3 weeks afterwards.
Okay, got you. So in the ED, if we do a scan, it's negative, we're suspecting a marginal ulcer, we'll certainly consult surgery, but in the meanwhile, we could give a PPI, or we could give some Pepcid or Maalox or something, just to relieve some of those symptoms.
Exactly.
Okay, great. So that makes sense for the marginal ulcer. And this, like you said, can happen at any point. And this can develop 10 years after procedure.
Yeah, exactly.
All right, great. So marginal ulcer, what's next?
So internal hernia, again, is that other thing that can still happen at any point during their course after a gastric bypass. And again, just to reiterate, these are rare complications. Less than 1% of all patients that we do gastric bypasses on are potentially going to get these complications, but they're serious when they occur. But with the internal hernia, that whole issue is we are, again, bringing up a loop of intestine or a length of jejunum up to that gastric pouch. And in doing so, we divide the mesentery, we divide the blood supply, part of the blood supply that goes to that, and we create a potential space where we make that loop up to the pouch. And that potential space we close, or at least I close, most surgeons close, to prevent bowel and other things from sneaking into that gap. But as you know, the whole point of these operations is that they're going to lose weight, and the expectation is that they're going to lose 150 pounds depending on where they're starting from, and that weight loss happens everywhere, including in their mesentery. So I'm really sewing fat to fat when I'm closing that defect, and if they lose weight there, those stitches can pull through, or that hernia or that potential space can reopen, and then that gives an opportunity again for bowel to sneak in there. So this is more of a longer term potential complication. Usually it's more than a year, 2 years out from surgery or longer, that we see that because it's associated with weight loss.
So you mean a small bowel is going to sneak up through that hole and sort of kink off and
Exactly.
get incarcerated, or
Exactly. Just like you see with a bowel obstruction after any operation, these internal hernia ones, because there's a physical defect that's allowing the bowel to get stuck in, the early recognition that they've had a bypass, early imaging with the CT scan or other imaging, but really CT scan is going to be the go-to, is going to give me or the surgeon a clue that there's something not right here. There's swirling of the mesentery, there's twisting of the bowel, there's obviously the obstruction. And if it's someone that's had a gastric bypass, and someone that's got an obstruction that appears to be due to an internal hernia, prompt surgical exploration is really the most important thing.
Is there a certain name for this type of hernia, or you just call it an internal hernia?
So it's I think the broad term is an internal hernia, but it's due to what we call the Peterson's defect. So that's the named space where that potential space is happening by bringing up the bowel up there.
Gotcha. Okay. All right. So that again is going to be a scan consult. If there's obstruction, obviously it's going to the OR. Okay. What else?
So with the bypass, those are really the big things long term. There can be rare episodes of strictures, really, again, more related to the ulcers. If those chronically occur, that can cause a stricture of the anastomosis.
Okay.
There is a condition called afferent limb syndrome. If there is, because we make two connections, we make that connection at the top from the stomach to the bowel, and then we reconnect the bypassed stomach and bowel further down. That's what makes the Y. If there is, for whatever reason, a slow transit through that lower connection, if there's an obstruction or partial obstruction at that lower connection, there can be backup or stasis of that elementary, or of the what's called the biliopancreatic limb, the part that's going up from that connection to the duodenum and up to the stomach. And so if there's kind of a slowdown or stasis of that limb, you can get bacterial overgrowth that can present with abdominal pain, again, nausea, vomiting, those kind of things. And if a CT scan shows that there's dilation of that limb, or if there's inflammation of that limb, that can be a cause of that. Often that is not need to be treated surgically. That if it's a bacterial overgrowth phenomenon and they are otherwise, showing signs that they're not completely obstructed, antibiotics are sometimes prescribed to sort of treat the bacterial overgrowth part of it, and then usually with time that gets better. Now, if there's a chronic obstruction, that may need surgical intervention down the road.
Okay, so the chronic obstruction, that would be a scan, would show that.
Yeah.
But the bacterial overgrowth, how are you going to make that diagnosis?
So again, if you see evidence of enteritis, especially of that
Okay, so inflammatory changes on that.
And then there is testing you can do endoscopically, a SIBO test, a small intestinal bacterial overgrowth breath test you can obtain. Again, that's usually done more as an outpatient setting, but it's really more the clinical thing with the CT and the CT findings.
Okay, and what's that called again when you're saying that type of obstruction?
Afferent limb syndrome.
Afferent limb syndrome, and that includes the obstruction and just the bacterial overgrowth.
The backflow, the backup of stuff because of that obstruction causing the bacterial overgrowth.
Great. What else?
Yeah, the way I'm making it sound, no one should get a gastric bypass, but they are a rare phenomenon. Those are really probably the big things. We see random, the paniculitis, again, those are more from excess skin from patients that have had a lot of excess skin, excess weight loss. But those, again, are usually not an ED sort of phenomenon. Those are probably the biggest things related to the bypass.
Okay, great. So let's transition over to the sleeve. Talk about what issues can happen there.
Yeah. So again, we'll talk about kind of the immediate post-op things and then the delayed things. So when it comes to the immediate post-op things, it's going to be very similar issues. for whatever reason, so that operation again is done laparoscopically. In that operation, we're not doing any reconnections, but we're using that stapler to make a long staple line and resect about 75% of the stomach. So we're leaving the inner part of the stomach as a tube or sleeve of stomach. So similarly, they can't eat and drink as much because the capacity of their stomach is decreased. But just like with the bypass, because of the part of the stomach that we're removing, that has a big impact hormonally and metabolically on the long-term benefits with diabetes and other factors. The sleeve short-term complications, again, bleeding, blood clots, leaks are going to be in that first couple of weeks. But one other short-term complication after sleeve gastrectomy can be splenic infarct. So in the nature of this operation, when we divide the short gastric vessels that kind of follow the top part of the stomach, and some of them feed directly from the stomach to the superior pole of the spleen, they can get a splenic infarct, which is usually a clinically non-significant problem. But not, someone may show up, and this is usually a short-term complication. So if someone shows up 3-4 days after sleeve gastrectomy, they've had, been doing fine, eating, drinking, or not really eating, but drinking well at that point. Again, they're going to get the CT scan. The CT scan may show this superior pole splenic infarct, and everyone doesn't know what to do with it because it sounds bad, but it's a known and expected issue after the surgery. They can present with left flank pain. They can present with left upper quadrant pain. They don't typically need anticoagulation or any other intervention. They usually resolve on their own. But again, right after surgery, if they see that, sometimes people can get nervous about it, but typically it's supportive management.
Okay, gotcha. So, and then if you see that, it's just going to be pain control and it'll resolve on. Okay.
Typically. Those are the things where, again, if someone shows up, those are the scans you're going to get are going to be very similar with both groups. Long-term, luckily, we don't have a lot of issues that we see that require usually ER visits for. I tell my ER colleagues, again, if someone shows up after, and that's why I really want to make sure they understand if they've had a bypass versus a sleeve, because if someone shows up 2, 3, 4 years out after a sleeve and they come in with abdominal pain or other abdominal complaints, they should treat them like anybody else that is showing up in the ER with abdominal pain or abdominal complaints. The sleeve itself really isn't a driving factor in most people, with the caveat of the long-term issues being of most concern is reflux. So as I mentioned earlier, that's something that can happen de novo in someone that maybe not even didn't have reflux before surgery. More commonly, it's someone that maybe had mild or controlled reflux, and then over time has developed worsening reflux, probably related to the sleeve. And so again, I'd really try to counsel patients before surgery about which operation may be better. But even with that, there are some of these patients that develop really bad heartburn symptoms after sleeve.
Okay, but you're not so worried about these. There's no potential for hernias. I mean, other than just regular hernias that someone could have, but from the surgery itself, there's no potential for that. Marginal ulcers are not a thing either.
Right, because it's a stomach to stomach closure, that assuming things heal in those first couple of weeks and there's no immediate leak, it's very rare to get an ulcer or a severe situation like a marginal ulcer that we see with the bypass.
Okay. Anything else we need to think about with the sleeve in particular?
Long term, really, again, that's why I think one of the reasons why we've been doing so many more of them is that once you get out a few weeks, a few months after surgery, other than the reflux issues, it's rare to have any long-term consequences. I will say for both operations, the other thing to discuss, I suppose, is with sudden weight loss or even not so sudden weight loss, the expectation is that these people lose their weight within 6 to 9 months after surgery. So it's somewhat gradual, but some people lose weight faster. That sudden weight loss can affect biliary issues, and so gallbladder complaints are very common after surgery. So about 10 to 15% of the time, someone will show back up in the ER or call me in the office with right upper quadrant pain and are having biliary symptoms. So that is a very common scenario. So we someone had a bypass, we go down the marginal ulcer and making sure there's no internal hernia stuff. But more often than not, it's the gallbladder that's causing issues.
Right, which is true for any rapid weight loss.
Exactly.
Okay. So, one thing I think about is, when I see these patients, they may come in for gastroenteritis or for a number of complaints. And with the Roux-en-Y patients, I'm sort of stuck feeling like I need to scan these patients every time because it's kind of tough. It's hard to get out of that. But it sounds like from what I'm hearing, and I want to get your take on this, it sounds like with the sleeve patients, at least who are quite far out, is there a way to sort of prevent having to CT them with non-specific abdominal issues
I
years
think
down the
that's
line?
yeah, I think that's absolutely right. I mean, I think if you can, I think part of the time, sometimes patients don't know what they have had, which is a problem. But as long as you can definitely, confirm that they've had a sleeve gastrectomy, not a gastric bypass, they're 2 years out. I think, if this is the first episode, yeah, probably a CT scan is warranted. But, if they
Okay.
show up 2 months later and they're having the same thing, I don't think you need to scan them every time. I do think they need to get followed up and worked up. Often that's with an upper GI study. It could be an endoscopy. It could be other things
Yeah.
to look for, gastritis, to look for esophagitis. But I think a CT scan is probably unnecessary.
And when do you distinguish between early and late? I mean, we mentioned just 2 years. That got me thinking, like, okay, at what point can you safely let go of worrying about the leak, the infection, the clot, and all that?
I mean, as a surgeon, unfortunately, I never stop thinking about it. But I think, the early complications I sort of say are going to be in the first month to 6 weeks. I think after that period, it's especially with the sleeve, it's going to be very unlikely related to those more serious complications.
Understood. Okay, great. This has been super helpful. Is there anything that we didn't talk about?
No, I think we as a group are doing more and more of these operations. The indications for bariatric surgery continue to increase. The guidelines for bariatric surgery by insurance companies hadn't been changed in 30 years up until recently, and still aren't. So the push to have lower BMI patients with more treating it like a metabolic operation are going to change and should change. And so we all are going to see more of these operations, which means that we're going to see more and more of these potential complications. I think having a high threshold and knowledge base about what to do with these patients is going to be important.
Amazing. Thank you so much. This is super helpful.
You're welcome.